अस्सलाम वालेकुम। अस्सलाम वालेकुम। मेरा नाम डॉक्टर सईद है। मैं सीनियर रजिस्ट्रार हूँ इधर फैसलाबाद इंस्टीट्यूट ऑफ कार्डियोलॉजी। और आज मैं आपको बताऊंगा कि बेसिक्स ऑफ कार्डियोलॉजी क्या है। इस तरह हम जो है पेशेंट को असेस कर सकते हैं कि ये कार्डियक पेशेंट है या फिर जो है ये पेशेंट कार्डियक पेशेंट नहीं है। तो इसके लिए हम जो है ये आपको सबसे पहले कुछ टर्मिनोलॉजीज बताएंगे। उसमें जो है द टर्म ये मायोकार्डियल इंजरी, व्हाट इज मायोकार्डियल इंजरी? द टर्म मायोकार्डियल इंजरी शुड बी यूज्ड when there is evidence of when there is evidence of elevated cardiac troponin values with at least one value above the 99th percentile of the upper reference limit. The myocardial injury is considered acute if there is a rise and fall of cardiac troponin value. Then myocardial infarction, it is described should be used when there is acute myocardial injury with clinical evidence of acute myocardial ischemia and detection of rise and fall of cardiac troponin values with at least one value above the 99th percentile upper reference limit, and at least one of the following symptoms of myocardial ischemia. Symptoms क्या हो सकती हैं कि the patient can say that patient says like this, I am having chest pain like this. This is Levine sign. And the patient says that I'm feeling chest pain. I will show you that the patient will say that I'm feeling chest pain, which is radiating to jaw and the left arm and the left arm. Okay, and both arms can radiate the chest pain. Then it is aggravated by walking and relieved by rest or sublingual nitrates. Now we can see that this is a pain of this is a cardiac pain, and it is more than the 20 minutes, and it is not brief. It is not pinpoint like you can see. This is not pinpoint. This is not cardiac pain. If patient can pinpoint, then we will not say that it's a cardiac pain. Patient until approved otherwise, we can advise stress testing for that. But most probably it is not cardiac. So symptoms of myocardial ischemia, new ischemic ECG changes. If you find new ischemic ECG changes, ST elevation, ST depression, T wave inversions, then their development of pathological Q waves, then it shows myocardial infarction, and imaging evidence of new loss of viable myocardium or new regional wall motion abnormality, then it's myocardial infarction. Identification of coronary thrombus by angiography or autopsy. These are the points are in favor of myocardial infarction. So we have cleared this, and now we are going to the towards the which is typical angina. What is typical angina? Meets following three characteristics. Constricted discomfort. I have shown you demonstrated that constricted discomfort in the front of chest or in the neck, jaw, shoulder, or arm, precipitated by physical exertion and relieved by rest or nitrate within 5 minutes. This is a typical angina. What is atypical angina? Atypical angina, it is that meets meets two of these characteristics, either chest pain or precipitated by physical exertion नहीं होगी और relieved by rest or nitrates नहीं होगा, ठीक है. So non-angina chest pain meets only one or none of these characteristics. So non-angina chest pain होगी. Again, what are the DDs of chest pain? Pericarditis, myocarditis. Pericarditis pain can present with pain like chest MI and myocarditis also, and aortic dissection. Even pulmonary embolism can present, and esophageal disorders. And then they can Brugada syndrome can present. So what are the basic investigations which we can do in these patients? If we find clear-cut STEMI, then we can proceed with the thrombolysis. If we does not find any STEMI and there are T-wave inversions and STT changes, then we can go for cardiac troponin and cardiac enzymes. Nowadays, we are doing high sensitive cardiac troponin levels, and these can be done within 3 hours, and then cardiac enzymes, no doubt, can be done, and these are more fruitful when patient presents within 15 days of the MI, and we can judge that it's a fresh event or an old event. And a very common terminology asked in exam is the high risk ACS. What is high risk? What are the features of high risk ACS? So I will clarify you this slide in the I will clarify in high risk ACS in this slide. And first of all, you can see that the first point is accelerating tempo of ischemic symptoms in the preceding 48 hours. If patient says that I was feeling a little bit pain, then it gradually increased over 48 hours, then we can say that it can be a pain of the heart, a cardiac pain or cardiac pain. And if patient presents with prolonged ongoing chest pain more than 20 minutes, moderate or likelihood of CAD, then the patient presents with shortness of breath, most likely due to ischemia. So then it can pulmonary edema. These are all high risk ACS, fall in the category of high risk ACS. If patient presents with rest angina with dynamic STT changes of more than 5, then it is high risk ACS. New or worsening rails S3 or murmur, hypotension, bradycardia, tachycardia, Bindle-Brown cough, new or presumed new, and sustained VT. These are the hard features of high risk ACS. Now I will show you some of the ECGs, and now you can judge that what are the different types of MIs. Now here you can see this ECG. This ECG shows 12 lead surface ECG, and there is normal axis and heart rate of almost 80 per minute, and you can see that there is V1, and there are ST elevations in V1, V2, V3, and V4. So this is anterior wall MI with RBB, and we will manage it as thrombolysis. This is another ECG. You can see on the screen. This is also a 12-lead surface ECG showing that there are ST elevations in 2, 3, and AVF, and there are ST depressions in 1 ABL, and also in the V1, V2, V3. So this is a case of infraposterior wall MI, and we will manage it as thrombolysis or primary PCI in the case of PCI capable hospital. This is the next ECG. You can see And this is very typical ECG, and shows that there is 12 lead surface ECG and left axis deviation and heart rate of almost 100 per minute. And there are tombstone pattern in V2 to V6, and there is shark fin sign in one AVL, and there are reciprocal ST repressions in 2-3 AVF. So this is anterolateral wall MI and tombstone pattern ECG, and it's very common ECG and shows some proximal region in the proximal LAD. The same territory involved, and you can see that 12-ray surface ECG with ST elevations in V1 to V4 and biphasic T waves in V5, and so this is a case of STEMI and anterior wall MI. Now, this is the case which is important to remember, that there is ST elevations in 1, 2, 3 and AVF, and reciprocal ST repressions in V1 to V4, 5 and 1 AVL. So this is a case of inferior-posterior wall MI, and there is also rhythm change. You can see that there are this P wave, and there are 2 P waves here, and then it's missed. So there is a Venke back type 1 second degree AV block, and this is very common in inferior wall MI. Now comes that there is also a very interesting ECG to share with you people, and you can see that this is a ECG of 12-lead surface ECG with the normal axis, and there are ST elevations and Q waves. Rather, it is more ST elevation in B2 to B4 and B5, and this is our anterior wall MI, and these are equivalent to STEMI. And so, any question regarding this? Very healthy discussion. If any questions, I will be entertained. So this is the discussion of today, and you hope in this video you will find a better understanding of the STEMI and STEMI patients. Thank you so much.